presenting the clinical and radiological evaluation of patients with craniosynostosis. And I will be presenting with Dr. Nina Stein, who has been introduced earlier on. We do not have any conflict of interest in relation to this talk. And our objectives today is to identify and correlate head shape appearances with various types of craniosynostosis. And also, at the end of the presentation, we would be able to determine when imaging is necessary and identify what imaging modality to request in order to advance the diagnosis and management of patients with craniosynostosis, and also to understand the pros and cons of various imaging modalities in craniosynostosis. Before I go any further, I would like to define what craniosynostosis is. A simple definition of craniosynostosis is premature closure of the cranial sutures with an abnormal head shape. So both of them would have to be present for the type of craniosynostosis that I am describing today. Craniosynostosis is a clinical condition that has been recognized almost from the times of Hippocrates and Galen. But it was Summarin in 1800 who described the anatomy of the cranial sutures and the results of premature closure. These cartoons illustrate the various cranial sutures. The presumed aim of the cranial sutures is to allow the skull to grow and accommodate the rapidly growing brain in children. So there are several sutures, but the clinically important sutures in craniosynostosis are the sagittal suture, which is a midline suture that extends from the anterior fontanelle to the posterior fontanelle. And then we have the coronal sutures, which are two, one on each side, which extends from what we call the anterolateral fontanelle to the anterior fontanelle. Then we've got the lambdoid sutures, which extends from the posterolateral fontanelle to the posterior fontanelle on each side. And then we've got the metopic suture, which extends in the midline from the anterior fontanelle to the nasion. Now, these are the clinically important sutures in craniosynostosis. Now, the craniosynostosis and the abnormal head shape that follows is on a principle in that if the cranial suture fuses prematurely, then growth in the direction perpendicular to the suture is impaired. That is to say, if the sagittal suture fuses prematurely, growth of the skull in the lateral directions is impaired. And as such, you have compensatory growth in the anterior-posterior direction, and you have an oblong shape, head shape, which is called scapocephaly. If a unilateral coronal synostosis occurs, then you have flattening of the head on that side because growth in a direction perpendicular to that suture will be impaired. The same thing when the lambdoid suture is involved. Now, when the metopic suture is involved, because it's a midline suture, growth in the lateral direction in the forehead is impaired, and you have a characteristic head shape. These head shapes are predictable clinically. Now, when do the fontanelles close? This is a common question. On the average, the posterior fontanelle is the first to close, usually closes within the ages of 2 to 3 months, but it could close early without any pathological significance. Anterior fontanelle closes around the age of 10 months, but early closure and late closure is very well known, and it's usually of no pathological significance. When did the sutures fuse? The sutures do actually remain open for quite a long time. The first one to close completely is the metopic suture, which closes by the age of 9 months. The other sutures close around the ages of 30 to 40 years. Why do we have craniosynostosis? Craniosynostosis, we believe, is a genetic condition and is due to upregulation of the genes that are involved in stimulating osteoblastic activity, that is bone growth, bone laydown, bone activity in the skull along the suture, and downregulation of osteoclastic activity. Osteoclastic activity, resorbs bone, and this leads to more bone deposition along the suture and sutural fusion. So when this is upregulated, then it does happen early, which gives the clinical condition of craniosynostosis. These genes are mainly fibroblast growth factor receptor genes. 3 of them have been well studied, 1 to 3, on different mutations, usually on multiple locus, on multiple loci. Now, there is there is an entity known as secondary craniosynostosis, and this is an abnormal head shape. It is not craniosynostosis at all, in that we don't have premature closure of the sutures. It is just that the head shape is abnormal because of a metabolic disorder, a hematologic disorder, or abnormal brain growth. One common condition in neurosurgery is ventriculoperitoneal shunting, which alters, brain growth sometimes, and could lead to craniosynostosis. There is also the condition of plagiocephaly that I'll talk about later. That is positional. Now, when we talk about primary craniosynostosis, that is true craniosynostosis now, they are usually classified into non-syndromic, which usually affects a single suture, and syndromic, which usually affect multiple sutures. The commonest examples of the syndromic craniosynostosis are Apert, Cruzon, and Pfeiffer syndromes. The clinical presentation of craniosynostosis is an abnormal head shape that is usually noticed by the parents at birth in over 90% of cases, in 98% of cases, and only 2% are noticed after birth. So as a gross rule, craniosynostosis is often detected at birth if it is looked out for. And it usually presents with an abnormal head shape. The commonest craniosynostosis is scaphocephaly. And the features of it involves the sagittal sinus, the sagittal suture from the anterior to the posterior fontanelle. Because head growth in the lateral direction is impaired, you have an oblong head shape, as depicted in this picture. Some of the other features that you see include this frontal buzzing, because the bone grows anteriorly. And then you have, that leads to temporal hollowing, which is what you see here. And then an occipital bullet, this is what you see here. Now, this can be, the degree of scaphocephaly can be measured by craniometrics, And what we do measure is an index called the cranial index or cephalic index. And it is defined as the AP length, that is the length from the front to the back, divided by the length from side to side, the widest side to side diameter. In sagittal craniosynostosis and schistocephaly, the index is usually less than 0.75. There are no units to it because the centimeters will cross out the centimeters. And it is the commonest, and it is common in males, with a ratio of 3:1. The diagnosis of this condition is usually clinical. Once, imaging does not have to be radiological to actually diagnose this condition. Looking at doing the physical examination is enough in most cases to diagnose schistocephaly. Now, for metopic craniosynostosis, which is premature closure of the metopic suture, which extends from the anterior fontanelle to the nasion and impairs growth in the lateral direction. So you have this pointed skull that looks like a triangle, and that's why it's referred to as trigonocephaly. Also, this is a characteristic appearance. Once you see these children in the clinic, it is very, very characteristic, and the diagnosis can be made on clinical clinical criteria alone. If you happen to get an X-ray or a CT scan, you will find the trigonocephaly being replicated on the axial images of the CT scan. Unicoronal synostosis is another fairly common type of synostosis in which one of the coronal sutures is prematurely fused. And you can see a ridge on this prematurely fused coronal suture, and you can see that the forehead here is recessed. There are other changes that do occur in the eyes. Previously, X-rays were done on these patients, and you can see that the orbits are elongated on the side. They appear elongated on the side of the craniosynostosis. This is the phenomenon usually referred to as the harlequin eye. It is described in the X-ray, although nowadays, when we see it clinically, we call it harlequin eye as well. So it's just that these eyes, because of the elongation, open more than the contralateral eye. You can see it in this baby and also in this baby. There are other things that happen on the face. So if you draw the midline in the lower and the mid face to join the upper part of the face, it is not straight. There is angulation towards the side of the synostosis. So also, these are characteristic clinical features. The combination of all these features is enough to make the diagnosis in most cases. Now, if you have bicoronal synostosis, both foreheads are recessed, and you don't have that unilateral differentiation. So but the forehead is recessed, and also most of the time one can make the diagnosis clinically. It's the condition, the head shape is usually referred to as brachycephaly. The AP diameter is short, and the side-to-side diameter is increased. And then you have a reversal of the cranial index. The cranial index can be even more than 1.0. Now, in lambdoid synostosis, lambdoid synostosis is the least common clinically significant single suture craniosynostosis. And what happens is depicted in this cartoon. So you have a unilaterally fused lambdoid suture. Because of that, the skull cannot grow in this direction. And as such, the ear does not go forward. So the ear is actually posterior to the contralateral ear. So this is, for patients with craniosynostosis, examination is usually recommended to be from the top of the head. That is when the mouth, the head shape will be best appreciated. So the ear is posterior, and you have this trapezoid shape of the skull from the top. And then you have this if you look at the back, and then you see that the ear is posterior to the contralateral ear. And when you draw the midline as well from the occiput, occipital protuberance forward and then occipital protuberance inferiorly, you also find out that it's not a straight line. Now, this has to be differentiated from positional plagiocephaly, in which the baby lies on the back of the head for prolonged periods, and everything, because of that pressure, is pushed forward, because the skull of the infant is softer than that of the adult, so it can be molded. So everything is pushed forward, so the air goes forward. So that's how to differentiate lambdoid synostosis from positional plagiocephaly. The other way of differentiating is the parallelogram. This looks like a parallelogram, not a trapezoid. So air forward, parallelogram appearance, everything just goes forward. The forehead on the ipsilateral side is also bulges forward. That is positional plagiocephaly. This is not craniosynostosis at all, and the treatment is different. One other differential diagnosis for craniosynostosis is caput. This is a birth canal issue. This usually resolves after a few days, and it's not craniosynostosis at all. The other is cephalhematoma, which is depicted here. This is also secondary to birth, and this hematoma, which does not cross suture lines, will resolve over the next few weeks. Sometimes it does calcify, but because of its its specific location and focality, the diagnosis can usually be made on clinical grounds. For the syndromic multisuture craniosynostosis, the two that are commonest are the Cruzon's and Apat's. So Apat's syndrome is autosomal dominant, and it's a mutation in the FGFR2 gene. You have multisutural craniosynostosis. You also have craniofacial abnormalities that are depicted in this baby, and syndactyly. That's why, it's sometimes described as acrocephalosyndactylia. And a significant number of the patients, in fact, most patients will have mental retardation as well. Because of the significant associated abnormalities, including hydrocephalus, which could have occur in these patients, we usually obtain an MRI in these patients. Cruzon is also a syndromic craniosynostosis. The key difference between the two is the mid-face hypoplasia that appears in Cruzon, and also the fact that Cruzon does not usually cause a lot of mental retardation. But other features of Cruzons include acanthosis nigricans, and it is due to a mutation of the FGFR gene for FGFR2 and FGFR3. So in summary, the clinical diagnosis of patients with craniosynostosis is based mainly on the head shape. We do request radiological investigations if we suspect that multiple sutures are involved, when the diagnosis is unclear clinically, and when there are confounding issues, when there are questions to be asked. And since most cases are single suture and the diagnosis can be made clinically, we rarely utilize radiological imaging in the management of craniosynostosis. This is just a case of one of our patients in which we required radiological imaging. This was a 9-month-old child who presented with us to us with schistocephaly. You can see the cranial index is less than 0.75. You can see the schistocephaly right here. And then the head circumference was above the 97th percentile, and the anterior fontanelle was bulging, which is uncommon in patients with craniosynostosis. So because of that, we obtained an MRI which showed hydrocephalus. Now we tried to find out why the patient had hydrocephalus, because on the MRI, we didn't see any aqueduct stenosis, we didn't see any obstructing lesion. And our postulation was that because there was no ridge on the sagittal suture, which is also unusual, we postulated that there might, that it is possible that maybe the ridge is on the interior of the bone, and this is what we found at surgery. So when we did the surgery and we removed the ridge that was compressing the superior sagittal sinus, CSF was now able to enter the drain into the superior sagittal sinus properly, and without doing a shunt at all, the hydrocephalus resolved, and the patient was well after surgery. So imaging can be sometimes invaluable in the management of these patients. There are other non-radiological imaging that we use to monitor patients that are treated by helmet therapy. And one of them is the 3D craniofacial photogrammetry, in which images are taken in 2D, but then the images are taken at different angles in 2D. It's like a scan, and then the images are now converted by computer to 3D, and then you have this kind of picture. But this is usually imaging is not usually done by radiologists; it's done by helmet orthotists.
Okay, I guess I'm taking over now. Can you hear me well? Yeah?
Yes, we can.
Okay, great. All right, so thank you, Femi. I'm going to be talking to you a little bit now about the different imaging modalities and what are the pros and cons in each one for the assessment of the craniosynostosis. So basically what we are looking for is very similar to what we see clinically, right? So in imaging, we're going to try to assess what kind of head shape we are looking, and we are going to look into the appearance of the sutures. So in the clinical assessment, you're going to palpate your sutures, you're going to try to find any ridging, any narrowing, any problems in the size of the fontanelles. And on imaging, you're basically trying to assess similar things, but looking at the width of the sutures, if they are completely fused or not, and also if there's any ridging or sclerosis in the margins of the suture. You're going to look at all the sutures. So if it's a single problem or if it's involving multiple sutures, and look at the shape of the orbits as well, right? So if clinically looking at the patient, you see those funny orbits, you're going to be able to see that on imaging as well. And as Femi just mentioned, imaging will be helpful to not only assess the sutures, but especially in those cases that have neurological issues or suspected syndromes, added imaging with MRIs and even skeletal surveys or dedicated skeletal X-rays of hands, for example, in cases of syndactyly and things like that, will provide additional information. So as already mentioned, schistocephaly is by far the most common type, right? And this is an example of a case. So you see again, as Femi mentioned, the enlargement of the anteroposterior length of the skull and narrowing in the lateral diameter. And if you can appreciate on this exam as well, it's quite difficult to look at the sutures in this case. And this is one of the problems of the skull X-ray, is that the degree of ossification in the bones of these really young babies is relatively low compared to older kids. And so it can become quite challenging, not only because of the projection, but also because of the bone density to assess if the sutures are present or not. In this particular case, obviously, we know already the head shape is abnormal, and that gives us a clue on which suture we should be looking at to find the problem, and we can see the ridge and the fusion of the sagittal suture here, right? In the town view and also in the AP view. So in terms of protocol, usually people take 3 to 4 views of the skull. If you're doing a skull X-ray, usually involves the town view, AP view, and lateral view. Some people repeat a lateral view on the contralateral side, which in our center, we don't do it, and we don't recommend in general. There we go. So ultrasound is also an image modality that you can use to assess sutures. This is a case illustrating how it looks like on ultrasound when you have a sagittal suture craniosynostosis. So again, you're trying to find narrowing of the suture, which in ultrasound, it should be at least 0.5. But in older kids, it starts narrowing, obviously, because the bones will mature. And so ultrasound is really only recommended up to 8-9 months of age. After that, you start getting a lot of false positives because of this bone maturity that will naturally narrow that space. And then you're also looking for this region deformity when the suture is completely closed. So this is, again, another case, but now on a CT, right? So this is what happens in CT. We try to reconstruct a 3D, and we use very low dose. So that's why we have these gaps as well. Like these are not only because of the skull density and the impressions of the gyra that sometimes happen, right? But it could be also because of the technique. And then you just have to adjust your thresholds of post-processing. And in this case, we see again a fusion in the sagittal suture, which has this ridge, this elevation. And so this is again a case of scaphalocephaly. So let's review a little bit of each imaging modality and what are the pros and cons. So X-rays, it can be extremely challenging in the young population, as I mentioned, because of the mineralization of the bones. It does have radiation exposure, although it's quite low, in average around 0.01 millisievert per view. So in average 0.03 millisieverts if you're doing a protocol with 3 views. And the problem with the X-rays is that the correlations with what is seen clinically and at surgery is not very good. So this paper that was published in 2021 was comparing the outcomes with the X-ray results, and they realized that, you know, it's around 75% with the patient final diagnosis, but what they found in surgery is even lower than that. And so, you know, if you have a complicated case, it's not really the ideal imaging modality. The advantages over ultrasound is that it gives you a broad overview of the head shape itself. It also shows you the deformities in the orbits, which ultrasound will be very targeted to the sutures that you are only interrogating. It can also show the cuprobitumen appearance if there's any increase in intracranial pressure developing because of the craniosynostosis. And it will work if you need to investigate children older than 8-9 months, whether ultrasound will become a little bit more challenging and can have more false positives. So with regards to ultrasound, in my opinion, one of the biggest challenges is that you need a dedicated group of sonographers that know the anatomy and know exactly what they are looking for, depending on the type of service you work. Sometimes this kind of setup don't necessarily are not necessarily easy to put together, and also the volume of cases might not be enough for those sonographers to keep their skills. And so there are not many centers that would use this technique because of this challenge. And then there's some pitfalls, right? And so we know that the skull have several different variants that can occur. And so you need to be familiar and understand how they would look like and the location of those when you're scanning, so you don't get into a pitfall. It's extremely rare, but you could potentially misinterpret a skull fracture with a suture if you're not experienced enough, right? I didn't see any case report in the literature, but I don't see why this wouldn't be possible given the way we image things. One of the disadvantages is that you're not going to be able to understand just looking at those ultrasound images how the skull shape looks like and if there's any orbital deformity. So it's very dedicated, right? So the protocol of the ultrasounds usually involves 4 or 5 sutures. 5 sutures, right? Like, so the 2 choroids, 2 lambdoids, and the sagittal suture. You can include the metopic as well, depending on the age of the patient, since it closes so early. And if you need to image other sutures and also the skull base, you're not going to be able to image, obviously. The false positives, as I mentioned, will increase if the patient is older. And the advantages over X-ray, obviously, is the lack of radiation. And you can also, during the examination, look at the intracranial segments and, for example, identify ventriculomegaly or potentially areas of encephalomalacia or something else that could be collaborating for that head shape. There are several published papers correlating the findings in ultrasound with the CTs using experienced sonographers, and they have a very good correlation with the findings that are seen in CT. So if you have a structure of experienced sonographer to scan these patients, it might be a good idea to set up if you want this to be as a screening test. Now, this is an example of potential pitfall on ultrasound, right? So you could potentially have a patient with a brachmatic bone, which is this Wormian bone that forms within the anterior fontanelle. And so, patients that have this, obviously, if you palpate the anterior fontanelle region, it will feel as if it's closed. And you could potentially be receiving referrals to double check for a craniosynostosis when it's just a brachmatic bone. So at this point, low-dose CT is the gold standard for diagnostic confirmation and the surgical planning. It allows the assessment of the head shape, the orbital deformities, the sutures in the skull base, synchondrosis, especially in cases of syndromic craniosynostosis. It also allows you to look for intracranial abnormalities, even though low-dose CT has poor resolution on the brain itself, you can still diagnose ventriculomegalies and other potential abnormalities that would be collaborating for an abnormal head shape. Obviously, the disadvantage is that it does have radiation exposure, but if you have good equipment and optimize enough your protocols, you could be using an ultra low CT protocol that could be much lower than normal head CT. So currently, I believe our protocol is 0.2 millisieverts. So it's still higher than the X-rays, which is 0.03, but much better than a regular CT, which is usually around 1.2 millisieverts in full dose. The problem with this kind of examination is that you may need to sedate some of these children to have good imaging. MRI is trying to take off for assessment of bone skull. So there's a technique called the black bone technique that has been published in the literature trying to characterize sutures. The advantage of MRI and what we currently use for sure is to assess the brain parenchyma and also to assess the anatomy of the veins, because these cases, especially the syndromic craniosynostosis, they can have venous anomalies associated with the skull deformities. And it's important for the surgeon to learn and to understand the anatomy before they start their correction procedures. Obviously, one of the major disadvantages is the fact that you need to sedate very young patients. And then also there's not enough literature to replace CT for this kind of assessment. And what you're looking for is very similar to CT. You're looking for the appearance of the sutures, the head shape, the orbit shape, and you can see in this example published in the literature, the region of the suture and the fusion. This is just what they are proposing as protocol. And if you look at these images, it reminds me quite a bit of those proton density fat-sided images we do in knees, for example. So anyway, we'll see what the future brings for the black bone on this kind of assessment. So the craniosynostosis and imaging, though, has some challenges, and one of them, I believe Dr. Olufemi Ajani has mentioned, with the fact that, majority of cases will be congenital, and in this age group, it's extremely hard sometimes to differentiate, what is a deformity related to birth or cephalohematoma, or even if the patients are premature, sometimes they just have this more dolichocephalic shape that, reminds scaphalocephaly. And so it takes a little longer for people to start realizing that funny shape funny shape head is actually something that needs investigation and needs treatment, and it's not something that will go away. And so based on even literature and what we observe in practice is that sometimes, it might take up to 3 to 4 months for people to and the family actually realize, okay, this is enough. We need to understand why this kid has this funny shape head. And so the problem is that, and perhaps Dr. Jenny can comment on that as well, is that my understanding is that most of the treatments and surgical procedures would be best if offered before 6 months of age. So now it gives us a shorter window to investigate and make diagnosis. So in terms of prevalence, craniosynostosis is actually relatively common, apart from what people think. So in the literature, it brings in 1 in about 2,000 births. So if you think in McMaster, I don't know, if we have 5,000 births a year, we have at least 2 kids born a year on our hospital, right? And the problem comes with differentiating plagiocephaly related to craniosynostosis of the lambdoid or the coronal suture versus the positional plagiocephaly, which Dr. Ajani also mentioned. And what we notice after the American Academy of Pediatrics started the campaign of Back to Sleep, which was to prevent sudden death, asking people to just put the babies in a prone position to go to sleep, is that the number of positional plagiocephaly went up. And so the amount of kids with abnormal head shapes is in needing investigation or attention, at least for clinical assessment, went up as well. And you know, if you have someone and not experienced enough to differentiate craniosynostosis from positional plagiocephaly, that's where, you know, sometimes we are faced with the challenge and people feel like they need imaging. And so what usually happens with these families is they are with their primary physician that suspects first, or they have the family, you know, insisting to have something done. And then instead of them sending directly to the neurosurgeon, they might order imaging or refer to a pediatrician. And so all these things take time and might delay even more and shorten even more this window between the 3 months and 6 months of age. So obviously, if you're thinking about imaging, you have to think about the principle of radiation protection. So you need to make sure that you have all your clinical history and your justification handy to sign an order for a CT or even an X-ray on these babies, right? Especially because there's a lot that you can do and diagnose just looking at the top of the head, as Dr. Ajani mentioned. So if you just place the baby in the exam table and look the top of the head, you're going to have a very good understanding of what more or less might be happening with this baby. And so this is a publication that indicates what Dr. Jenny mentioned about the parallelogram and the trapezoid format. And you can see that on imaging as well. So if you have cases of plagiocephaly, you also will have your parallelograms. If you have cases of craniosynostosis, as we see here on this left coronal suture being partially fused, you're going to have your trapezoid. So what about this case? So initially, you know, you're looking at this case, you're seeing the abnormal shape of the orbits. I usually tell my students, like, if the orbit is pointing up, right, the inquisitive or the harlequin orbits, make sure you look at your coronal sutures. If you have unilateral coronal synostosis, usually the abnormal orbit will be pointing to the orbit, to the suture that is fused. So in this particular case, the head shape as well, if you look at the lateral diameter, it looks prominent, and you have a little bit of shortening in the AP diameter. So this is kind of like a brachycephalic shape. You have very poor visualization of the coronal sutures, but it looks like it might be here. Not 100% sure if they are partially fused or not. We see a nicely open sagittal and no obvious ridging or anything like that. So on this particular case, it was a CT was done to clarify, and interestingly enough, what we found was stenosis of the confluence of the sagittal and the bilateral lambdoid. So completely unexpected and almost simulating bicoronal synostosis. Now, on this particular case here, it's a little bit more obvious, right? Like we have, despite the very prominent widening of the sagittal suture, and then we see the lambdoids, well, we can see sclerosis in the inferior aspect of the bilateral coronal sutures. This was a case of syndromic kid. I believe it's called Safri syndrome, the name of it. So this was the CT on this case again, and pretty much what we were seeing in X-ray is what we are seeing in the CT. This is a very interesting case because, when you look at the head shape, you see the trapezoid configuration, right? It's very obvious that your coronal suture is fused. You have widening of the fontanelle, and this is another important thing is that, often your fontanelle is actually not reduced in size or closed. It can be quite widened and in a triangular shape instead of the diamond shape in cases of craniosynostosis. So in this particular case, it was quite enlarged. And we see the orbital deformity, that inquisitive eye, right? Like pointing towards your coronal suture that is fused. And there's another suture here that is fused, which was initially missed, and then in the second review was found, but it was mislabeled, which is the fusion of the mastoid occipital suture. So this is not lambdoid, this is not squamous, this is the occipitomastoid suture that was fused as well in this case. And then obviously we have to image these kids when we have post-surgical findings suspicious for recurrence or complications. And in this particular case, we have signs of recurrence. So we see basically a refusion of the surgical correction. So in summary, ideally we should just order imaging after the physical exam was performed, ideally by someone experienced, ideally a neurosurgeon, and yet it was non-conclusive. And so the neurosurgeon will decide what is needed. Most of the time, what is ordered for us to do is low dose CT, because that will give them, in terms of like what they need in terms of the head shape, the orbits, and also for surgical planning, how they are going to approach the case. Obviously, if you don't have this kind of technology, or if you're working in an environment where your CT machine is too old and you don't have very low dose protocols, you can still resource to other techniques. Or if you are just trying to, for whatever reason, assess a particular suture and do a very target scan, you can attempt an ultrasound. I know people in other centers, we don't do ultrasound for skull assessment of craniosynostosis in McMaster. I believe C-Kids is not doing as well, except that Dr. Elka Miller, who was working in CHIO, now works in C-Kids, and she has experience on that. I believe she actually gave a recent lecture on ultrasound for this kind of assessment, and maybe she will be someone to link with if we need some ultrasounds for this kind of investigation. But at this point, we don't do in McMaster. And then MRI, obviously, it's at research level, and potentially in the next few years with new technology now that is arising, especially with AI tools, we might be able to use more MRI for this kind of assessment. So I appreciate your time. I hope this was helpful information, and we are open for questions.
Yeah. Thanks a lot, Dr. Stein and Ajani. Excellent presentation and overview of this common pathology in kids. And we may have some questions. So it is a clinical diagnosis, but can you really intervene without a planning CT exam?
So I can comment on what I read in the literature, but
Perfect.
maybe, I don't know, Femi, if you want to answer this first. What I read, Ramiro, is that there are some surgeons that feel comfortable in taking the patient to OR without imaging, just based on physical exam. But I'm not sure if that's like the majority of the neurosurgeons. So
because that case, Nina, that you show about the occipital mastoid fusion, suture fusion, that is wow. I mean, I imagine a surgeon can be surprised when he opens up and he finds out that is not the lambdoid, but the lambdoid, but instead the occipital mastoid future fused. Anyway, that's just
yeah, and I mean, most of the time that's a rare case, right? Like most of the time is not like that.
Exactly.
Yeah,
What would
most
you
of the
have to
time,
say, Femi, about it?
yeah, most of the time our patients come to the OR without any imaging in about between 90 and 95% of the cases. When we have a doubt, like things don't, follow the textbook appearance of these patients when you examine them, then we obtain imaging. I remember that patient with the occipitomastoid suture, it was because we had doubts, and that's why we did the imaging. So
Okay. Wow, amazing. So, and the dose, the low dose is good enough, or there are more promising techniques to even lower the dose even further, Nina?
Oh yeah, there's a very good machine coming down the pipes. Hopefully, Dr. Donelan and leadership in the hospital will be able to obtain that for us in our McMaster Children's Hospital, which is photon counting technology, right? So this is a brand new technology that is arising now in the radiology field. There's several services in Europe and the United States that have this machine already and have been publishing on the topic. And I just presented this morning actually about CT and radiation dose, and it's quite amazing the amount of radiation that these machines apply and the amount of information that we gather with very, very little exposure. And even like, for example, a chest CT for high resolution, the paper that I presented this morning was able to lower the dose in 50%. So I suspect, for cases of craniosynostosis that we already work with very low dose, it will be a similar thing. Like we might be able to do this potentially with less than 0.1 millisievert, right?
Now, in terms of differential diagnoses, which would be the one most commonly found, and which is the mean of imaging that you use to diagnose it?
Well, I think the main challenge, and again, maybe Dr. Jenny can comment on that, but what I observed based on the referrals that come to us, the main challenge is to differentiate positional versus craniosynostosis. And I'm talking about like the referrals that we get from the community. I'm not talking about the referrals that come from our neurosurgeons. And it might be a matter of just people being more comfortable in, relying on the physical exam to differentiate these things, because it's fine details, right, in the head shape, and it might be challenging.
Mhm.
Do you have
Femi,
the
anything
same
to comment on that?
experience, Femi, like when you get referrals?
Yes, the commonest one that we have to differentiate is the positional plagiocephaly. But sometimes we've had cases with dolichocephaly without craniosynostosis. In those cases, they don't get the temporal hollowing, and there will be physical examination findings that will sort of put a doubt into the diagnosis, and then we get imaging in those cases. Yeah, usually it's that, oh, it wasn't present at birth. There's no temporal hollowing. The frontal bossing is not very impressive. The occipital bulletin is not very impressive, but the cranial index is 0.71 or 0.72. In those cases, there are two ways. Number one, sometimes we give them a second appointment in about a month to reassess, or we go ahead and obtain imaging.
And I think also there's a paper published by people in Ireland. So apparently they have a group in Ireland or UK, I think it's Ireland, that they are center of referral in the country for craniosynostosis. And what they do is to, instead of getting radiological images to assess and consult if they need to see the patient or not, they actually request the primary physicians and families to send them the standardized pictures of the patients, so they can, provide an opinion if they need a referral or not. I thought that was very interesting. It's a paper published. So I do know that our neurosurgeons, they have like a special path. Maybe Femi, if you don't mind to comment on that, like how when people refer to you guys with kids with abnormal head shape, does it have like a expedite appointment, or how does it work in terms of how fast you guys are able to assess the patient and things like that?
Yeah, Femi, and just to add on that question, excellent question by Nina, is the fact that how often do you get direct referral from the family doctor? And I was also wondering if it wouldn't be of use for the pediatrician to have some kind of triage function before it gets referred to you. Just questions.
Yeah, to answer the first one, patients that get referred to us get fast-tracked into the clinic for two main reasons. Number one, we want to sort it out as quickly as possible. And number two, the earlier we operate, the better. And also, there are surgical options that are available when the patient is less than 4 months old, that will not be available if the patient is older. The younger the patient, the easier it is to cut the bone. And then the older, the more difficult it is to cut the bone, and also molding and all these things do go better with younger infants. Then in terms of the second question, can you remind me again about what the second question is all about? Oh,
If
yeah, the
it's
referrals.
yes.
Yeah. So we get referrals from family physicians and pediatricians. I would say it's about 50-50. We get a lot of referrals directly from family physicians. Once they see an abnormal head shape, they refer the patients to us. Sometimes it comes from the pediatricians. I don't know how it is in the community, who gets to see a pediatrician or who gets to see a family physician first. But we also noticed that some of the patients already come in with X-rays, and some of them, a smaller percentage, will come in with CT scans already done.
Now, one more question, maybe the last one. So how big is the proportion of the syndromic craniosynostosis? either the uppers of Couson with regards to the simply cosmetic one? How much
Yeah.
is the proportion?
Yeah, I would say the ratio is at least 9-1. The syndromic ones are not as common as the single suture ones.
Okay. Okay. And the main motive of consult from families or from patients is cosmetic, no?
Previously we used to say cosmetic,
Yeah.
but nowadays, because of intracranial pressure measurements and neuropsychological assessments that have been done on patients that have not been operated, we usually, recommend surgery for almost every confirmed craniosynostosis case that comes to us. It's not every one of them that is going to have raised intracranial pressure. It's going to be a minority, and it's not. It's also going to be a small percentage that will develop learning difficulties in future. But we don't have tools to predict who is going to develop those issues. So so that's why we tend to
Recommend surgery.
recommend surgery, but we give the patients, the families, the information, and then they come to a decision based on the information. And the surgery is relatively safe.
Great. Okay. No, I really appreciate the two of you coming in today for the rounds. It was excellent overview by people who do this every week, every month. And thank you, Femi. Thank you, Nina, once again. And thanks to the audience for coming on board. And we wish you an excellent summer, and we will meet again in the next edition of Regional Rounds. Thanks again.
Thank you for the opportunity. Have a good night.
Thank you.
Thank you very much.
Thank you.